Councillor Hakim, thanks so much for that lovely welcome. Good afternoon, everyone who's here in the room with us at the University of Melbourne and also streaming us via the dreaded Zoom or some other provider today, this afternoon. Great to have you with us. And welcome on behalf of the Peter Doherty Institute for Infection and Immunity to Pandemic Proofing the Future, or as I like to call it, what the hell just happened? And how do we make sure that doesn't happen again? I'm Virginia Trioli from ABC Radio and TV, and I'm delighted to be your moderator today for a discussion in two parts. We first have a discussion with two of the most eminent immunologists in the country, and we're speaking to them in just a moment, and then a broader discussion about what we've been through, what we learnt, and what we need to do now. I'd like to add my acknowledgement of the traditional owners and custodians of these lands that they've taken such beautiful care of for more than 60,000 years, and to pay my respects to elders past, present and emerging. So, over a year in, today we take an in-depth look at Australia's response. What have we learnt? What could we do differently next time? And will there be a next time? That's just yes, isn't it? Yes, there'll be a next time, so we don't have to worry with that one. We've gathered an esteemed panel to discuss the lessons learned in the areas of vaccines, immunology, public health, clinical and diagnostics, and I'll introduce that panel shortly. But first, let's have a quick chat with Professor Sharon Lewin and Professor Peter Doherty. I've got your long descriptions here. Shall we do them? No, says Peter. Of course we should. We'll do a little bit at least. Melbourne Laureate Professor Sharon Lewin AO. I only asked that about their long and distinguished credentials because you know them, because they have been some of the two of the most important public faces through this entire pandemic. And we've come to rely on them and trust their institute for their expert guidance and analysis. But it's important to know that Sharon Lewin is the director of the Doherty Institute and is an internationally renowned researcher in HIV cure and an infectious diseases physician. And Nobel laureate Professor Peter Doherty is patron and namesake of the Doherty Institute. He shared the Nobel Prize with Rolf Zingernagel for their discoveries about transplantation and killer T-cell mediated immunity. And I've woken him up any number of mornings, and Sharon as well, in order to say, come on the show and explain to us what the hell is going on. Great to see you both. Good afternoon. I haven't seen you in person, I think, ever. Yeah, all year. And Peter, not for a very, very long time. If I was to get you to briefly reflect, each of you, on 2020 and where we are now, what would you say, Sharon?
Well, I've had a very similar reaction to you, like what the hell happened last year. But if I could reflect on 2020, I have very mixed feelings. My reflection on what happened in Australia, and I think, wow, I honestly do think, wow, that we can live like this now, and have thought a lot about how we got here. And of course,
the side of the MCG at the weekend was just amazing for you, wasn't it?
It was really quite emotional to look at it, and then remember Anzac Day last year with this sort of desolate Melbourne at the time. So I think a lot about that, about what we did as a country, but then thinking, you know, what's going on in the rest of the world, and we're not out of this yet, and the enormous pain and suffering that the pandemic has brought. So, you know, just a few high-level thoughts, of course, as a scientist and as a physician, what incredible achievement science has brought the world. Of course, it has not been perfect, our response. There's lots of room to improve, as we'll discuss, but how incredible that we now have 8 vaccines in use currently and vaccinating people like mad in just such a short time of a new virus, understanding how it transmits, how it causes disease, how you might treat it, how you might prevent it. It's been incredible to see this as a virologist, actually.
Peter?
Yeah, I've now been working on infection and immunity and published my first paper 55 years back. And so I'm part of the living fossil record of this area. And I feel a bit like it's Jurassic Park, you know, I've been recreated. But I've been very, very busy. And I wrote a book on pandemics back in 2013. And basically I've just been on a constant learning slope since the beginning of this thing started. The science has been fantastic. I mean, when the SARS hit China and back in 2002, the science now is just incredibly better. And the fact is that when the sequence of the virus was first published in mid-January, people are already starting to make vaccines. Yeah. And we've gone through this enormously rapid evolution. Early on, I think some of us were giving mixed messages. We thought one thing and we've learnt another. And of course, I think we can congratulate ourselves. And it's not the scientists, it's the community, the politicians in Australia that we've done so well with it, and we're in such good shape. The only thing I'd say is now we all have to get vaccinated.
Yes, I doubt there'd be any. Well, we'll see if there's anyone in this room who would argue with that. But what did we get wrong? What did we get right early on? What's your sort of, biggest aha reflection on that, Sharon?
Well, I think as a global community, what we got wrong, and I heard Helen Clark say this, and I think it's so true, that February was a missed opportunity, meaning that February was when Australia moved into action. Actually, Australia started moving into action back in early January,
late January, yeah.
Developing tests, making sure that labs around the country could diagnose, creating the right committees to inform policy, and by early February, we were already testing like mad and really thinking a lot about this. February was a lost month, a lost opportunity where this virus spread like mad throughout the world.
What could we have done or should we have done at that point?
Well, I try not to be too to think Australia's too perfect. We did a pretty good job in February. There were certainly slip-ups with Ruby Princess and what we were doing with cruise ships, our delay. We were talking earlier about masks, but we didn't really have the science at that stage. That we all thought it was droplet spread, not aerosol, and we were learning on the job. I want to go back a bit for the world and then talk a little bit about China because, of course, we have been very dependent on pandemic response by open communication with each other. So had we known earlier about what was going on in China, had we known it was a coronavirus very early in December or late in December, maybe things would have been different as well. And I don't want to point the finger or blame, because it's not about blame, it's about reflection of where we could have intervened to lead to a difference. And doing something back in December could have led to a difference. Doing something in the rest of the world in February could have led to a different outcome.
Do you agree with the lost opportunities in February? Was February a hinge moment?
Well, I think we took the opportunities. We stopped the planes flying out of Wuhan and we stopped planes from China coming in. And the United States, Europe, much slower to do that. By the time the United States stopped it, they were getting the most of the virus from Europe, in fact. So we reacted very quickly and very, very responsibly. I think the fact of our institute, which was put in place, it was 5 years old the year before, which brought together the practical side of infectious disease in Victoria and the academic side, has proved enormously powerful. Mike Catton and Julian Drews had a PCR test out, the test that we all talk about. Within days of the sequence being published in mid-January, they isolated the virus at the end of the later in the month, and we were the first person to distribute it worldwide. So we really did well. But there's a long investment that goes into that, a long investment in infrastructure, in administrative arrangements, in research, which has been greatly supported by Victorian government, by the City of Melbourne, which has been terrific. And it moves more and more to be evidence-based. In fact, I was at a meeting a few years back where someone suggested the best rate around the world would be with the World Parliament of Mayors, because they're actually close to the action. States are pretty good, and we all know about Canberra. They obeyed. They did the right thing, but without the states, would they? I don't know. Maybe.
Yeah, and
couldn't possibly comment.
I think, it's not just about infrastructure, it's about that workforce, that sort of deep expertise in whether it's epidemiology and modelling, virology, immunology. You can't create that sort of expertise overnight.
And going into it in January and February, what was your sense of faith and confidence in everything you described there about the workforce, the healthcare workforce, about the infrastructure, about the connections between institutions, about the level of science where they could move with alacrity into the areas they needed to go? How are you feeling about that at that stage?
Well, basically, right at the beginning, I was kind of switched off. I thought I was retiring. I'm turning 80 in 2020. We'd finished our last big grant, our last big influenza grant. I'd almost finished my book on tennis, which will come out later this year or early next year. And I was kind of laid back. And then I came along to one of our strategy meetings where everyone's talking about this. I realised, hell, something's happening here. and I also realised that a lot of our team leaders who were on these strategy meetings, we've been having them 3 times a week, were rapidly getting pretty tired. And because they're online to Europe and to America at night and in the wee small hours of the morning. So I joined up as a junior member of our communications team. That's what I've been doing. I take, with respect, Virginia, even though I've been on your program, I take the lower level stuff.
Now I know.
It's always a like to talk.
Here was I thinking it was a signal moment whenever we got him on the program. Did you have faith that we were set up correctly to deal with this?
Well, back in January, February, I thought this would be localised Asian, largely related problem. At the very beginning, having seen what happened with SARS, what happens with new strains of influenza, and that very much meant that in the Australian context, we took this very seriously from, as soon as many of us heard about it in January because of where we're geographically located. It was only probably sort of mid to late February when we began seeing what's unfolding in northern Italy and Europe, then you really realise this is a level that none of us had ever imagined.
Yeah, we've been watching horror stories unfold. I mean, we watched the whole horror of Trump through 2020, which was an incredible disaster. But it's America, and the US can move very, very fast. And as we've seen under Biden, they're very effective and they move very fast.
Oh, no, the vaccination program's been a thing to behold off the back of that.
And we see the country transform. The country does that, it breaks backwards and forwards. But we've been watching successive horror stories. The current one is in India.
That's right.
Which is appalling.
So, given all that, what we've discussed, what would you say was the most important lesson learned from the Australian response? And then I'll get you to reflect on the most important lesson learned from the international response. Sharon?
I think from the Australian response, we've learnt that policy needs to be driven by science, and by working in partnership, you can deliver extraordinary things, and I think that's what we've seen.
Was that ever a question?
Well, I'm sure Peter would comment on that in the context of climate science,
Well, we've got two situations in this country. I mean, we've got two major crises. We've got the COVID crisis, which is acute, and we'll go through, and we've got the climate crisis, which is, Biden's just had a meeting on this. As I said, if it wasn't for COVID, I'd be in Washington now at a meeting of the National Academies of Science, the 3 American National Academies, and the Nobel Foundation in Washington, focused on climate science. I was interviewed, but actually because of COVID, I was interviewed on a panel that largely dealt with COVID. So we've got these two crises. On one hand, our national government has listened to the science on the medical side, and medicine's not difficult for politicians, actually, to support medicine, politically popular and not a difficult challenge. Yeah. And on the other hand, we've got the situation with climate change.
Yeah, and I don't think this has come out of the blue. My background's in HIV. Australia responded incredibly well to HIV in the early 80s, different era, I know, but right through that whole time, we've had bipartisan support for our HIV response and an outstanding HIV response. So for me, it was very reminiscent of that. It wasn't very quickly government set up their advisory panels. The advisory panels like the AHPBC, the Australian Health Principal Protection Committee, are in existence all the time, but now people know what that acronym is. They've always listened to scientists, but we have a history of doing that well, and it is interesting to reflect on the US, where public health for HIV has never been that good, and they've got very large numbers, but the science has been spectacular, and I think we're seeing that right now. I mean, we can all look at what's transpired, what unfolded in the US on the public health front, but what they're doing on the science front is also spectacular.
Peter, what's the most important lesson learned from last year and these months as well from the international response?
I think basically, Virginia, that there's a whole bunch of lessons. We've got what really this is an enormous experiment in a way, and I think with these coronaviruses, there were 2 of them circulating in the human population before 2000. Now there are 6. Since 2000, we've had 4 more human coronaviruses, 5 in fact, 1 burnt out, the original SARS. We now have 6 human coronaviruses circulating. Something dramatically has changed. I mean, one thing that's changed is enormous passenger air travel out of China and areas where they have live animal and live bird markets, which are extremely dangerous and may have been the trigger of this. We don't know that. but they may have been. So that's changed. But we need to be ready for more of these things. So we need to learn from it, and we need to learn from the lessons across the world, the different experiments we've seen done in different countries by different political leaders, and because of location, our location as an island has been enormously important. We need to look at it from the economic, the sociological, the medical, the preventive perspective, and come to conclusions about how we should handle this and get global agreements. I mean, what should have happened right at the beginning is that the planes out of China should have stopped. They didn't do that. And that we need to do. It would save the airline industry billions of dollars apart from everyone else. And we also need drugs that work against these broad classes of viruses. We still don't have good drugs for COVID. It's ridiculous, but we don't.
Yeah,
we could have done that.
That's the treatment of the disease is something we'll get to in our next panel discussion.
Though the vaccines are very specific, and you've got to make them for each particular virus, you can make drugs against a whole class of viruses. We've got drugs against all the flu viruses, all the AIDS-type viruses, and we need to do that for all these different types of viruses that are a threat.
Just before we move to the other panel, because we need to wrap, we could talk all afternoon, but we need to wrap here. What would be the one thing that you'd ensure was the top of the to-do list when we're faced with the next pandemic? Sharon?
I think we have to absolutely have mechanisms in place that allow global sharing of information really quickly, and you have to have those partnerships with all countries, rich and poor, and also make sure both rich and poor, or high and low income, have the capacity to detect and respond to something really quickly, because time is of the essence, and that lost time for us, just weeks or months, made a very big difference.
Peter?
Well, Sharon's really described the international imperative, really. I think within Australia, with our state-based health systems, I wondered how that would work. I've always been worried by that, but it worked remarkably well. But we have seen a lot of places it could be improved. And I think both in the policy and in the interactions between. So I hope we'll learn those lessons, make those improvements. It doesn't mean we've got to abandon the basic model we've got, but I think we can make it better.
Sharon Lewin, Peter Doherty, thanks so much.
Thank you, Virginia.
Thank you. I'll ask you to say thanks so much. So we say goodbye to Sharon and Peter, but let me introduce our panel now, and I'll ask them just to come up to the stage. They know where they're sitting. If you'd like to use these steps, if it's easier for you, you may. Otherwise, just leap on up. But sitting here from my left, your right, across, Professor Kanta Subbarao, who's the Director of the World Health Organization Collaborating Centre for Reference and Research on Influenza. She's a virologist and physician. And before starting at the Doherty, Kanta was at the helm of the Emerging Respiratory Viruses section of the Lab of Infectious Diseases at the National Institutes of Health in the US, where she worked on the original SARS coronavirus and later MERS. Professor Deborah Williamson, who's the Director of Clinical Microbiology at the Royal Melbourne Hospital and Deputy Director of the Microbiological Diagnostic Unit Public Health Laboratory at the Doherty Institute. Associate Professor Stephen Tong, who's an infectious diseases physician with the Royal Melbourne Hospital's Victorian Infectious Diseases Service and co-lead of clinical research at the Doherty Institute. Nafisa Youssef, who's a community researcher and project manager at the World Health Organization's Collaborating Centre for Viral Hepatitis, Doherty Institute. And her research aims to understand how Hep B perinatal services are delivered to Victorian women and their infants. And she's worked during the COVID-19 pandemic in the public housing towers during that hard lockdown. And Dr. Nicholas Gerardin is a postdoctoral fellow who focuses on the role of unconventional immune cells in cancer. In response to COVID-19, he, to use that word, rapidly pivoted and is working with lab head Professor Dale Godfrey and others on a COVID-19 vaccine candidate. How are we going to squeeze all this into 30 minutes? Oh, put your phones on silent, come on. I make my guests on air answer that live to air, so consider yourself lucky. So we'll do a quick fire response then if we can, just one response each, minute each at the worst. What's the one thing in your experience that should be focused on for the next pandemic arising from what you've learnt from this pandemic, Nicholas?
So I think I'd probably reflect on what Sharon and Peter said and point out that really one of the great success stories in the last year has been the contribution of science. And there's been many challenges set, and science has continued to rise to that challenge. And probably, this is across many aspects of the challenges over the last year, but probably the most obvious one is the development of these vaccines so incredibly quickly. And I guess one of the key points is that the reason that's been able to happen so quickly is that this is a result of many, many decades, really, of investment in science. And so really, I think to make sure that we're ready to pivot next time round, continued investment in science is going to be absolutely critical. And across a diversity of different types of areas of science, I guess, because we really don't know exactly what the next pandemic is going to look like. So that'll hold us in really great stead to be able to make that pivot very effectively.
Nafisa?
It's really hard to pick one, but I'm going to say I would love for us to strengthen our coordination and communication among our services. So whether that is primary, tertiary, government, community, mental health, social. If we have that strong coordination, we're better to respond to a crisis, but also better respond to a community needs in terms of on the ground.
And you've had particular experience of that. Steve?
Treatments. So you mentioned that we don't have great treatments at the moment, and I think we need to be better prepared, both what Peter said in terms of pipeline for treatments, but also having a clinical trials infrastructure so that we can test those treatments for people who become sick with COVID. And I don't think we've had a very good infrastructure in Australia to make that happen very quickly.
Deb?
Preparedness, no. Not waiting, no. This needs to be people's jobs. So the response last year was basically run by bits of people who had other jobs. So people were doing their jobs and then doing the response on top of it. And we need to ring fence people, resources for preparedness. And I've been on so many meetings recently where people say, oh, it's so nice to get back to business as usual. That's not what we should be doing now. Business as usual isn't business as usual. And you look overseas, and the UK got so much wrong, but they actually got a lot right. And they're establishing a new health security agency just last week. New Zealand announced actually a disbanding of their health service and the establishment of a centralised health system, which actually goes some way towards what Nafisa was talking about, and establishment of a New Zealand public health agency. Now, I appreciate that to do that here would require an iron stomach and a backbone of steel, but I think that we do need some structural change for pandemic preparedness.
Kanta?
So I would say being open in science to new facts and new knowledge, being open-minded and being open to all different aspects and learning as we go. We're going to have to learn from what's happened, as Peter and Sharon said, going forward, and we've learned from what we knew before, but we've had to be flexible and change our messaging as we've learned.
That's a really good place to start the conversation more broadly, because we can all imagine, can't we, and I'm sure we probably are thinking of a key example of that. We've got a couple in the room right now, masks, and the slowness with which the world dealt with the possibility that maybe it wasn't just droplet transmitted, it was airborne, it was aerosolised, and that masks were important. Your organisation, the World Health Organisation, was saying, no, not masks, we don't recommend masks, and I was the bunny on air who said, no, don't put your masks on because the World Health Organisation says don't do it. Why is there such slowness and resistance to changing evidence and to changing your mind?
Yeah, so that's quite complicated. I think that part of it is that people started in fairly entrenched positions, which is always a problem. And in medical science, the terminology and the way we thought about airborne viruses was quite different from what the aerosol scientists and engineers think about. So there's now been more of a meeting of minds, which we needed. But people were very entrenched, and there were implications of these terms. The implications were would surgical masks be enough? Would you need to use P2 or N95 masks? So it was loaded because of the implications of which term you used. So my message now is it's not binary. We shouldn't be entrenched and say it's this and not that. It's a continuum. And these viruses, like influenza and now SARS-CoV-2, are airborne transmission. We should not get fixated on particle size, but should acknowledge that it's airborne.
At a Commonwealth level, the expert advisory group still does not recognise it formally as airborne. Isn't that a problem?
Well, I would like them not to think of it in that binary term, and that it is, in fact, there's plenty of evidence, epidemiologic and scientific, that the virus is transmitted through the air.
Deb, we heard during the regular daily press conferences here in Victoria, get tested, get tested. What have you learnt in the hospital diagnostic setting that could make us much better prepared next time, given that testing is part of our DNA now? We front up for it, we'll do it regularly, we'll do it in waves when there's a new threat. What changes or what should change?
Yeah, look, I think your point about the communication and testing, I actually thought that was very strong, and it got better throughout the pandemic, and particularly providing people with feedback on their test results quickly, the text messaging and stuff. I think that was very useful. What should change? Look, again, it comes back to Kanta's excellent point about entrenched positions. So many in the testing space think that it's PCR or nothing. You have a PCR test, and that's really the gold standard and the only test that you can do. But we need to think outside the box. We need to think about taking testing to the patients, and that's point of care, or individuals, that's point of care testing. And I look at the vaccine space, and there's so much work and translational science now, based on years of investment in vaccine development. And I just feel that hasn't necessarily been the case in the diagnostic space. We've rested on our laurels a little bit, in as much as we're reliant on one technology. So I'd like to see much more focus on scalable, rapid, and robust point-of-care testing. When we looked at saliva as an alternative diagnostic method quite early on in the pandemic, and some colleagues in the field, I have to say, thought we were going to hell in a handcart, because we were thinking, deviating, if you like, from normal testing processes. But that's proved to be something that's, really useful to scale up testing and to make it accessible to individuals who may not have appreciated having a swab shoved up their nose every day.
Yeah. Stevie, in your line of work, how important is that particular challenge that Kanta's thrown out there about being open and flexible and changing your mind, considering the evidence and being prepared to move and change? Is that going to be central to a better response next time?
Yeah, I think critical. Like, obviously, with something like COVID, no one knows how to treat it when it first comes out. And so people are trying all kinds of different things. And in fact, I think in some ways, a lot of the world perhaps moved too quickly, that we were willing to use treatments which had no evidence behind them, so hydroxychloroquine, for example. And so potentially hundreds of thousands of patients have actually been harmed by the use, the evidence being established, of the use of therapies like that. So we actually need to, in some ways, move slowly as well and use the evidence that's accumulating, but to develop that evidence, and that's where we failed. Certainly in places like America, I think, where all these off-label medicines were being used without the appropriate evidence behind it.
That's a really interesting challenge, because that's the flip side of being flexible and open-minded, isn't it? That you can't move too quickly and without any evidence base, Nick.
Yeah, excuse me, I completely agree. I mean, the vaccine space has been an interesting one, because these first wave of vaccines have been developed so very rapidly with really very little knowledge of the actual virus itself. Turns out they've been very successful, but there still is a lot we don't know about them. And so, for example, how long is the immunity that we get from the vaccine, does it stay with us for? Will there be a waning effect of our immune response? Pfizer recently came out and said that it seems likely that we'll need a third dose 6 to 12 months after the second, and potentially annual doses. The other key issue is, question mark really, is how effective are these vaccines against potential variants in the virus? And so this is a very rapidly moving field. And so that's why it's actually really great that we have, I think there's more than 100 or so sort of second generation vaccines that are sort of moving through the pipeline. And they're all sort of they're being constructed based on this sort of knowledge base that we've established over the last year. So yeah, it's something that's sort of, it's feeding back into itself, and we'll hopefully have this development and enhancement of the vaccine response as time goes on.
Nafisa, the public housing towers lockdown was, I think everyone acknowledges, if not an absolute disgrace, then something that we never really want to see again. I'm I'm going to ask you what flows from that and what we've learned and what we wouldn't do and what we would do again. But I actually want to go backwards because I think it's probably a better way of asking and answering the question, which is, what did we know back then that might have meant that we didn't have to proceed in that direction?
Not much, I'm going to be honest. I think there's as much confusion in the community as in the public health field. And I just want to acknowledge that, yes, I've worked at the towers during the lockdown, but it's different to when you live there, when you're in the community, and I think no one will really understand the experience unless you're in the hard lockdown.
Of course.
But the key things that I really want to touch on is it's fantastic. I'm so grateful and glad that we have vaccines. I'm so glad that we've been able to move quickly in the response. But the key thing is, if we're not able to communicate those communications or those processes in a way that makes sense for the community, we're not going to get much. And I think that's one of the key things we've learned during the hard lockdown, especially for communities that have been disproportionately affected by COVID-19. The hard lockdown, for example, is that the communication wasn't great. And hopefully going forward, what would be great to see is community partnerships and building trust with communities early on, and having representation and diversity within the workforce that can relate and that can resonate with the community on the ground. Because I think a lot of things that could be hopefully avoided was just through that sort of almost disconnection between community and the response. So hopefully that's something that we could improve on and learn from COVID.
Yeah. Let me expand that notion of communication, connection, sharing information in the community, because we are here in Australia part of a broader Asian and Southeast Asian community. And I'd like to go around the panel, anyone who would like to respond to this. Do you think that we paid enough regard to the experience of Southeast Asian countries and their experiences of SARS, MERS, H1N1 in our response here in Australia? Was that regard or that sort of consideration of them as peer countries when it comes to a public health response, was that adequate? Did we take advantage of that enough or not? Kanta, would you like to go first?
No, I'm trying to mull that over and see what I would say. I think that in one way, one of the things that struck me when I heard about this virus first being identified in Wuhan was that they built on their SARS and avian influenza experience a surveillance system to identify clusters of atypical pneumonia cases. And that's how they identified this cluster. So whether we have such a surveillance or not, a syndromic surveillance of that nature, where there would be a trigger to investigate, and that was based on their experience of SARS and avian influenza, bird flu, and so on.
Deb?
Yeah, look, it comes back from, I guess, from a diagnostic and surveillance perspective, it does come back to connectivity, and it is devastatingly hard to share information between laboratories in Victoria and across the country still.
Why?
Yeah, so it's a largely historical reasons. Certainly here in Victoria, we don't have something called a statewide pathology network. So every hospital and every diagnostic lab here operates essentially independently. And the laboratory information systems, they don't talk to each other, and it relies on, which we have here, thankfully, collegial and collaborative relationships, so personal relationships. You pick up the phone to people.
And that's still the case 1 year into this?
Correct. Yeah, so again, It comes back to those structural changes, and this has catalyzed some changes, but there's still a long way to go, and we need to stop operating independently and start operating as a system, not just here in Victoria, but nationally, and as we've heard, internationally as well.
I was just going to say, I'm no expert on this, but from what I've read, it seems that some of those Southeast Asian countries, Thailand, Vietnam, have had sort of remarkably less COVID than would be anticipated. And do you guys have a feel for whether that's something to do about even the location of that, or is it something that maybe they've learned from their previous experiences?
That's something that's I know is still under fervent discussion. Steve, anything you want to add there?
Yeah, I remember visiting Japan a couple of years ago, and probably this was before COVID, of course, but 20-25% of people were wearing masks on public transport. So clearly, culturally, that was already, it would have been easy to scale that up. So I think, previous pandemics and just the overall culture probably made it easier to implement public health policy and changes, and very quickly. So, for example, Taiwan very quickly was able to track by various electronic means pretty much every single person who got tested who came into the country, all those kinds of things in a very rapid and scalable manner.
Yeah. Nick, vaccine development is the real, success story, amongst others, of the global response to COVID-19. Do you have a view on how globally the development or even the rollout of the vaccines could have been or should be, indeed, because it's still real time, improved?
Yeah, that's a tricky one. I'm no logistics expert, that's for sure. Certainly, it's a very challenging logistics exercise to say we're going to vaccinate not only a country but an entire planet, really. So, I guess I could just reflect on the faster we can get everybody vaccinated, the better.
Yeah.
And the better we can be prepared and not have to rely on lockdowns and things like that. So there's probably several things that can be put in place, but, I think it's quite varied as to what they could be, and probably to some extent policy is going to be a driving factor there, but maybe I'll leave that at that point there. Yeah.
But as a layperson, am I right in concluding that it appears from the outside that there's been a greater willingness to share, proprietary information than perhaps there may have been in the past, or not? Or is this just what the international community does when something like this comes along?
Yeah, absolutely. The scientific community has really changed dramatically in the last year in terms of open access, sharing information very, very quickly.
Yeah.
Even before people publish their recent findings, they're uploading them to databases that are open to the public, really. So that's been a dramatic change in the sort of scientific research sphere in general. And I think it has made a dramatic difference around the world, allowing other scientists that are halfway around the world to adapt what they're working on. So that's been absolutely huge, and it's one of those things that you hope that stays around post-pandemic, really, because it seems to be a really important part of science.
Kanta?
Yeah, I was going to say that to address your question about whether there's more interaction and more willingness to share, even amongst the pharmaceutical industry, there is during a pandemic, and this has been seen before with influenza pandemics, and there generally is an agreement that you put aside all of that for the duration of the pandemic and then and share everything openly.
A bit of human common sense kicks in, does it? Which is, I know, not always common. Kanta, you worked on SARS, MERS and now COVID-19. Has there been a recurring theme of something that we still haven't learned from these?
So we have learned a lot, and we've built a lot on what we've learned, so that should be acknowledged. But there are things that we learn each time. I think both SARS and MERS, as Peter said, were not transmitted efficiently from person to person. And I remember it was around February 1st of last year when I realized that it was actually spreading person to person, and I thought that was a game changer. This was going to be like influenza, not like SARS. So I think we have learned something new with this, but we are having to learn as we go. We had expected that the coronaviruses wouldn't change very much, that we'd make a vaccine and it would work for years like measles vaccine does without needing to be updated. That was the expectation based on the biology as we understood it. But that's really changed. I mean, we're seeing variants emerge and we're having to think about updating vaccines. So we're now going back to sort of thinking about how we do this for influenza and how that can inform what we need to do for COVID-19.
In talking about what we need to do next and how we'll need to prepare, the reality is that we're governed, as we mentioned here and discussed before, that we're governed by several layers of government, and they work as a federation apparently, and work together reasonably well, I guess, with various problems along the way. But as scientists, as researchers, as people who work at the ground, you advise, you do your work, you do your research, you peer review it, you try and advance it, and then if you're in that direct communication setting, you advise accordingly, and then a decision is taken entirely separate from what you have concluded, from what you believe, from what you would argue for. I know you're not in a position to comment, politically speaking, and I'm not asking you to, but I am asking you today, is that connection working? Is it actually working between where you sit and where the policymakers are sitting, the decision makers are sitting? Is that communication effective? Is that understanding and respect and trust at the right place that it needs to be for the next one? Steve, can I start with you?
I think in general it has been, and I think our overall response has demonstrated to that, and we've all talked about how science has driven our policy, so I think that communication has been pretty good. And I think as scientists, we only see, part of the elephant as such. We can advise on the medical, scientific aspects, but I'm not an economist. I can't advise on what the impact of lockdown will be on our society in general. So you do need policymakers who see the whole picture and make decisions based on that and not just on one person's view.
Nafisa?
Interesting. I think yes and no. I think for the most part, yes. But there have definitely been times where, I just wanted to put my head on the wall because things weren't being translated on the ground. For example, we've seen confusions around testing, we've seen confusions around, quarantine versus what, so I think sometimes it doesn't translate well. Particularly if you think about communities who, I'm privileged, I speak English, I work in the health sector, but if you don't speak English or you have a disability or you live in a rural area from an Indigenous community, whatever, group you might fit into, things look quite different. We don't understand, a lot of things that are coming from the news. We don't really, have that background. So it's really about how do we translate the policy and the science into everyday language? How do we make sure our systems are culturally safe? How do we, Chancellor Hakeem touched on trauma. There's a collective global trauma. There's, I think, a trauma between people who are working in the response, but there's also a particular trauma for people from marginalised communities if you're in the lockdown, but also a particular one around for people who are from those communities working in the sector, because you sort of never sleep. You're working in the sector, but you're also the translator, the interpreter, the person who people, come to you for news. And the scariest part is when you don't know the answer to yourself because things are just changing so quickly. So for me, it's about how do we translate that knowledge to the community? How do we get it to the community in a timely manner, in an accessible manner?
Yeah, and we won't get a second chance at getting that done more quickly next time. We really won't.
Fingers crossed.
Yeah, well. Deb?
Yes, I would agree. I think for the big ticket items, the closure of the international border, the national and state lockdowns, and yes, informed by science, and those decisive decisions have put us where they are now. What makes me nervous is preparedness for the next one, and the next one, and the next one, which could all come at the same time. And I still don't have a good sense about what we're learning from that. We talk about we need to learn, but how are we actually going to learn? What will that look like? Will it be a series of national reviews, or how will we collectively learn at all levels? So we talk about needing to learn, but we need to work out how we're going to do that.
Kanta?
Yeah, I'd say that a lot has worked very well. And we're very fortunate in where we are. But I think, as Deb said, going forward, I think there are some things that I really do worry about. I think that there's still being, at the scientific level, people in different parts of the country are doing their own thing, very much the same things, and we're competing for the same pot of money. The United States got around that competition a few years ago by essentially creating centers of excellence where people got their money. They didn't have to compete for the grant. They were funded, they were well funded, and they exchanged a lot of information. It worked really well for influenza, got rid of all the internal competition. And so I worry that we've been competing for the same pots of money to do very important things in a very short period of time. And in terms of preparedness, I think we do need to look at how this will happen going forward.
So and I'm going to take nods, I guess, or head shaking from Sharon and Peter in the front row here. But it occurs to me that, and I say this only slightly tongue-in-cheek, is it possible that COVID-19 is the best thing that's ever happened to scientific funding in this country?
Yet to be determined, I'd say. I agree. I think it'll be very interesting to see how things change from this point on. But
I mean, we've been having this discussion for decades now about how underfunded it is, how funding is cut from it again and again and again, how great institutions here in Melbourne have scrabbled for funding and on sunny days have been, generously given a grant. Is this the game changer for research funding?
Yeah, and science has risen in the last year. I think, if anything, science has said, this is what we do. We can solve these major issues. So, you know, if there's no change from this point, you're going to be scratching your head, that's for sure.
What do you think, Steve?
Yeah, I certainly hope so, and I hope it extends beyond COVID, of course, infectious diseases. You know, there's not sufficient funding across all our systems. You know, some of our NHMRC grants, there's 5% success rates, when probably 50% of the grants that were put in should have been funded. So I think we could massively expand the amount of funding that's available.
We don't have much time left, so I just wanted to sort of go around, I guess, and ask you a crystal ball question, if I can. But it's not, I know, because you've all got your minds firmly focused on the next thing anyway. When or what will the next pandemic be? And perhaps, probably more important than that, for all the policymakers who I know are tuned in this morning and watching from their desks and with bated breath and paying close attention to these highly credentialed professionals to whom you're listening right now and jotting down everything they're saying, what would you like them to know? I'll start with you if I can, Nick.
I was hoping you weren't going to start with me, but that's all right. I think one of the key things, we spoke about enhancing funding and continuing funding, but I think one of the key things is we don't have a crystal ball, and we don't know what the next pandemic will be, a major health issue. And so ensuring that there's a pretty broad diversity of funding available, I think that would probably keep
What do you mean by diversity of funding?
So whether it's in, biomedical science, whether it's very specific diseases, some of the major breakthroughs we've had in understanding COVID over the last year, have been built upon breakthroughs in technologies. mRNA has been one in the news lately. So investing diversely across the gamut of science, they typically tend to feed into, the different disciplines feed into each other. And so I think that's really important. Yeah.
Nafisa?
Look, the truth is COVID-19 has really just highlighted the inequity in our healthcare system, period. So I think there's going to be disparities for communities, before COVID and after COVID, unfortunately. One thing that I would love to see is partnership with communities. If we have trust and partnerships with communities before, the next pandemic, whatever that might be, I think we're more likely to successfully respond better as a community, as Victorians.
But we're such a complacent lot. I mean, Deb's been referencing that already, going back to situation, normal and the like.
Yeah.
Don't you think or fear that we're probably just going to forget all that?
We potentially could happen, but I think from what we've learned in terms of depending how that happens, the how is really important, is really just going, well, we've seen what happened, and the only way that we can move forward is really if we partner together, whether that is organisations or communities. One way we could really do it is I would love to see community consultations happen across the country. What worked from, we're hearing from the experts in terms of people working in the sector, but from the community, what's it like for them? What worked well for them? What would they see differently? So having this sort of conversations with community across the country would be fantastic, and that to shape the next response, whatever that might be.
Steve?
In my narrow space of clinical trials, I'd love to see better infrastructure from community through to hospital through to intensive care units.
What does that look like?
On the field, I think we need staffing in our hospital systems so that patients can be, there's capacity to recruit patients into clinical trials. And we don't really have that. So in the UK they did, and they were within a week able to very rapidly get the whole 180 hospitals to be recruiting into clinical trials. And that's really driven what we know about how best to treat this infection now. We don't have that in Australia, and I think it wouldn't be a large investment to have a kind of peacetime ready infrastructure that could then be switched on and ramped up when the time comes.
Well, that's really interesting, because the narrative out of this one, of course, has been that vaccines will get us out of this pandemic. But is that necessarily always going to be the response, or should be? It's
not, and even in this case it might not be. There's these variants of concern, whether we get to a certain level of population immunity through vaccination, we still don't know. Our rollout's in trouble at the moment, so I don't think we can assume that vaccines will be the silver bullet. We still need better treatments for the disease.
And we have people living with long COVID and whatever other disease might sort of hopefully not develop from that. Are we focused on that? Are we focused on treating and managing those who may stay with consequences of the disease?
Very little to date, and I think that will come. But again, to work out how best to help those people who have long COVID, you need to do the clinical trials, because otherwise we'll be throwing different treatments at them or different therapies without knowing which one will work unless you actually test it appropriately.
Deb?
Yeah, look, I mentioned that we can't go back to business as usual, and that's largely because, we've thrown everything up in the air and we don't know how it's going to land, particularly with regard to the collateral damage, if you like, for other infectious diseases. I mean, you look at countries where their public health infrastructure has been literally overwhelmed by COVID cases, and what that has meant is they haven't been able to test and treat for other infections.
Yeah.
And newsflash, viral people, we have actually been in a pandemic of antimicrobial resistance for many decades. And I think that the COVID pandemic will really compound that problem of antimicrobial resistance. And that makes me very nervous because we don't know what's going to happen, I guess, what that post-COVID antibiotic era is going to look like.
Just don't, because I saw Norman Swan's 3-part series on this, which is just aired, which is available on iView right now. And I got halfway through episode 3 and thought, I actually don't know if I can handle this right now. It's enough dealing with it. COVID-19 has not been tamped down.
It's not that antimicrobial resistance per se has looked at COVID and gone, I'll just go and have a cup of tea now because COVID's here, and then I'll come back when COVID's over. It hasn't. It's still there. It's still the dark matter that's there.
So on that, is there technology we should be working on or pursuing right now?
Yeah, look, I mentioned I think that we need to be looking to the future for new technologies which are just within our grasp for diagnostics, nanotechnology, microfluidics, massively parallel sequencing. And we haven't mentioned sequencing here, but that's been a real success story of this pandemic. So we need to be looking at those and bringing them into the diagnostic space. But again, that requires a will and resource to do so.
So we're coming back to money again. Money and commitment and taking it seriously enough.
Correct.
Yeah, okay. Kanta?
Yeah, I would say, again, agree with everything that's been said and the fact that money and commitment. And I think that there's a danger of remaining reactive. And we have to be reactive in the event of a pandemic, but what do we switch to next? And we have to actually look back and make sure that everything that we've learned from this continues to be covered in the future, and yet not forget all the diseases that we've ignored.
And how do we do that?
Money.
Here was I hoping for some lofty principle, and of course it always comes back to that, as it should, and hopefully that has been, maybe that will turn out to be one silver lining from the most dreadful year we'll probably ever go through. Can I please ask you to thank our really wonderful panel today that have been with us, Hunter, Nick, Nafisa, Deb and Steve as well. That's it for our discussion here today, and thank you to all of our panellists and of course to Sharon and Peter as well, and for those who have joined us here at the University of Melbourne and those of you who have joined us online for this really terrific discussion. A recording of this event will be available via the Doherty Institute and the Melbourne Knowledge Week websites, so just look those up in whatever search engine you like, the Doherty Institute and Melbourne Knowledge Week, and you can get to see and share with your friends this recording as well. Now also, can I just recommend to you the Doherty Institute's podcast, Infection and Immunity Evidence Explained. And the next episode is on vaccine confidence and hesitancy, the very big elephant in the room right now. And that drops this Friday, so please search that out. Thanks for being with us, and have a great afternoon. Take care. Thank you.